the outset, I would like to thank the organizers for having invited me to speak on this topic, empowering children with type 1 diabetes and their caretakers. Now, why is this essential? Consider these facts. Any child with diabetes has to take at least 3, if not more, injections of insulin every day, has to check blood sugar, ideally 6 to 10 times a day, or use a CGM. Every time they eat, they have to match the carbohydrate content of the food with the bolus insulin dose. And anytime they decide to indulge in physical activity outside the normal play time, they have to modify the insulin dose or take an extra snack to prevent hypoglycemia. They have to know how to identify hypoglycemia early and its first aid management, including glucagon administration. When the child falls sick, and children fall sick pretty often, besides treating the illness, they have to check the blood sugar, check the blood or urine ketones every 2 to 4 hours, and probably take additional insulin supplements based on the sugar level, and consume a lot of salty or sweet liquids depending upon the sugar level, so that they don't go into diabetic ketoacidosis. Now they have to know how to do all this because they have to do it themselves, and they have to integrate all this into their lifestyle so that they can lead a normal life at the same time. The worst part of it is that this has to be done 24 hours a day, 7 days a week, 365 days a year, and there is no off day. So if we say that good diabetes control rests on 4 pillars: insulin therapy, meal planning, planned physical activity, and therapeutic monitoring at home, the foundation on which these pillars rest is the most important: patient education and, even more important, emotional stability. We may have patients who know everything and yet they are poorly controlled. Why? Because they are not in the right frame of mind to do what they know. So before you sow the seeds of education in the patient's mind, you have to address their doubts, their queries, their anxieties. Any new patient who comes to us with a child with type 1 diabetes has 6 major concerns. Whether they voice it or not, they are there. There is denial. Do I really have diabetes? Resentment. Why me? Guilt. Is it because of some act of omission or commission on our part? And then parents feel guilty to prick their children so often in a day. So there are false hopes. Is there some alternative to insulin therapy? Is there a cure for diabetes? Now, diabetes treatment is expensive. So they're worried about finances, and they're worried, does my child really have any future? Do I really have to do something for this child, or have I lost a child? If you do not address these concerns, whether the patient voices them or not, you will not be able to educate the patient in self-management because they will not be willing to listen. So the first thing is get the patient to accept that the child has diabetes, even though the diagnosis may be very obvious clinically. You may sometimes have to do certain tests like C-peptide, antibody tests to prove it to the patient that this is diabetes. To overcome the resentment, get the patient to meet some of the senior, well-adjusted diabetics. When they meet them, they realize that they are not the only ones. There are others who are sailing in the same boat as they are. Explain to them that the diabetes is not due to any act of omission or commission on their part. It is an accident of nature. It's an autoimmune disease. And giving insulin injections, pricking the child for blood sugar tests, one should not feel guilty. One cannot feel guilty about giving a lifeline to the child. Their false hopes should be replaced with real hopes. No tablet is going to work. Only insulin is required. For this, if they meet others who have tried other methods of treatment in the past and realize they're falling, when they talk to such patients, they believe them more than what they would believe a doctor. And they must be told that a cure will come one day. When it will come, we don't know. But when it comes, your child's body should be in a fit shape to avail of that cure. Patients must be assured that if they cannot afford the treatment, There are enough NGOs who will provide insulin strips, etc., free of cost. And they must be assured that the child will have a bright future provided the diabetes is well controlled. And the best way to assure them is to introduce them to some of the others who have developed diabetes 30 years ago, who are now in their 40s and they had it as a child and they're doing very well. There are three main concerns about the future that all patients have. Will my child be able to study? Will he have a career? Can he or she marry? Can he or she bear a child? What is the risk that the child will have diabetes? And what about the long-term complications of diabetes? What will be the lifespan of my child? Here, you have to paint a positive picture and a truthful positive picture that the child can study like any other child, can take up virtually any career, can marry, can have children, and the risk of the child getting diabetes would be less than 5 or 6%. But at the same time, you have to stress that this will be possible only if there is consistent good control. And by stressing this, you are enlisting the patient's cooperation for regular follow-up and regular screening. Every parent must be informed that the child is a normal child except that he has diabetes. And it is not a diabetic child. So the child must be treated like a normal child. Diabetes should be in the background. Again, parents get very hassled when they see that the sugars are not normal all the time. They must be informed that perfection in diabetes management is impossible. What is desirable is near perfection, and we have to have practical goals. And lastly, parents must be told that eating healthy, exercising regularly is not just for the child. It is for everybody in the family. In fact, many of our patients tell us that after the child developed diabetes, the entire family's health improved, and patients must take note of this. Patients want to know, how do I cope with the social stigma attached to diabetes? Remember, a child with diabetes can continue to do whatever he or she was doing before diabetes developed, and they can do everything that a non-diabetic child can do. This must be stressed. Again, type 1 diabetes is not a visible handicap, but parents must be warned that they have to reveal, not to everybody, but to relevant persons. If they do not reveal to relevant persons, how will the child take insulin outside the house? If the child develops hypoglycemia, who will be there to help the child? And when they reveal, they have to be bold. They don't have to be meek. They don't have to be apologetic. They have to stress on how well the child controls his condition and yet leads a normal life. This is a plus point. Patients should be made aware and introduced to those who have done very well in their studies, who have done well in their career, and have found good partners in life and are respected in their field and community. They should be encouraged to see that the child excels in some field. Secrecy before marriage, never. If somebody will not marry the child because he or she is a diabetic, well, the child deserves somebody better. Obtaining a job may be difficult, of course, but retaining it is easier because those who are well controlled with diabetes have learned to lead a disciplined life. What about school? The child is normal in all other respects other than having diabetes, and the child can participate in all extracurricular activities with certain precautions. This has to be stressed. There are 4 things which have to be informed to the school authorities. 1, of course, besides that the child has diabetes, allow time or provide help for blood sugar checking and insulin shots. If you have a nurse in the school, well and good. If not, the teacher can help without having a medico-legal responsibility. Allow a snack before activity or in case a meal is delayed. The teacher and maybe a few close friends should be familiar with the early symptoms of hypoglycemia and its first aid management, and a hypo kit should be provided to the teacher, and the teacher should inform the parents if the child asks to go to the toilet often, because this would mean that the child's control is poor. Other than these 4 points, the child will be normal or like any other normal child in the school. All this has to be told to every patient at the first visit, before you begin the education, and has to be repeated often. And this is why a mental health team is a very, very, very important part of any type 1 diabetes clinic. And besides that, a support group is also very important. And the support group, ideally, like the Juvenile Diabetes Foundation that we founded in 1983, must cater to all classes and all categories of patients. How will that help? The seniors, the adults in the group can guide, they can inspire and serve as role models. And those who were careless in the initial years can serve as a subtle warning for the new entrants. The intelligent in the group can continue to guide the not so intelligent. The rich may finance and adopt the poor, and the influential can help the less influential, the less fortunate with school admissions, jobs, and so on. Now, who is to be educated? Who should be the recipients of diabetes self-management education? Besides the parents, besides the child or the adolescents, in selected cases, the siblings and the grandparents, the school authorities, and if possible, the treating primary physician or pediatrician. And who would be the trainers besides the doctor who specializes in type 1 diabetes, the nutritionist and the mental health specialist? We must have certified type 1 diabetes educators. ISPE has now started a course for type 1 diabetes educators in pediatric age group, and senior parents and patients can serve as excellent educators and social workers in the group, because they can relate to the patient's problems, they can empathize, and they have better acceptance amongst the patients. They can speak with authority because they have practical knowledge, they are doing it themselves. They are best suited to help newcomers in the initial turbulent phase after diagnosis, and they can serve as role models. Where is the education to be imparted? At the time of diagnosis, it is usually done in the hospital, in the inpatient, or in cases which come with mild early symptoms, it can be done on OPD basis. It is important to have a weekly comprehensive care clinic, which includes the doctor, the nutritionist, the social worker, the educator, and the mental health team. A monthly theme-based meeting, one-day educational camps, and what we in the JDF started in 1983-84 is 3 to 4 days residential camps for patient education and counseling. Let me tell you a little bit about these camps. Now, frequent revision of education is very important, like you need to frequently recharge the batteries. This is very important. And staying in touch with the patient is very important. In fact, when one of my students did a thesis, she found that only by staying in touch with patients, answering their queries once in a week, the control could be much better. Coming to our residential camps, the first one was held in 1984 in India. It was a 4-day residential camp. Subsequently, we have 3-day residential camps. The theme is education and counseling in an atmosphere of fun. These camps facilitate establishment of enduring friendships amongst the patients. So when they go back, they can help and guide each other. It is an annual event. We hold it in Lonavala during the winter season. And the cost is very low. Actuals only, or free for those who cannot afford. No doctor, no member of the medical team has ever charged anything for conducting and attending the camps. The camp program is divided in 4 sessions. We have the breakfast to lunch session, where on day 1, we have introduction to each other and introduction to diabetes, and on day 2, nutrition management. These are common sessions for the entire group. Before each meal, we have procedures performed under supervision. So patients are checked while they take the insulin, check the sugar, check the urine ketones, and any mistakes they made are pointed out to them. Between lunch and dinner, there are 4 sessions over 2 days. Decision making, that is acting on your self-monitored blood glucose, hypoglycemia, sick day, and coping with diabetes. For these sessions, we divide the patients into 4 main groups and 2 special groups. The 4 main groups are parents of those below 6, parents of those above 6, adolescents, and young adults. And 2 special groups are those who need very basic education and the pumpers, present and potential. And post-dinner, we have an entertainment program. On the third day, we have a quiz contest to reinforce education and a brainstorming session. Procedures going on under supervision at the camp, the quiz contest, where we have fathers group, mothers group, boys group, girls group, with a leader in each group who discusses each case scenario with all the other members in the team and then presents it. Post dinner, we have entertainment program each night. On the first night, it is a pure entertainment program where children show to their parents and others what they are capable of, excellent dancing, music, etc. And on the second day, we have entertainment with a message where skits, plays, or themes such as sick day or hypoglycemia are enacted. Besides the camps, which are for education and counseling, we conduct sports events, treks and hikes with a dual purpose. One, to make it a point to prove to these children that they can do everything. And number two, to guide them how they can do all this and yet keep their diabetes in excellent control. This is some data from two of our camps conducted in 2014 and 2015. What we did is we checked the HbA1c of patients who are from Bombay at the time of the camp and 3 months after the camp. So in 2014, there were 57 such patients. The HbA1c at the camp was 9.1. 3 months later, it was 8.8. In 2015, the HbA1c was 8.7. And at the end of the camp, it was 3 months after the camp, it was 8.4. Now, of these patients, there were 20 who attended both the camps. For these 20 patients, the mean HbA1c at the start of the first camp was 8.7. 3 months later, it had dropped to 8.1. At the second camp, it had slightly risen 8.3. And 3 months after the second camp, it was much lower than 3 months after the first camp, 7.9. And the number of patients with HbA1c below 7.5, which at that time was the ISPAD ID before the 2018 guidelines. The number with HbA1c below 7.5 was 2 at the start of the first camp. And by the period when the second camp was over and 3 months beyond that, almost half the patients, 9 out of 20, had HbA1c below 7.5. This is our team. This is Dr. Manoj Bhatavdekar, who heads our mental health team, and I would say is the most important member of the team. Dr. Dalal, who looks after the young adults, and Mr. Vipul Mehta, who is our CEO, a very, very devoted person. Our JDF team, and JDF was founded, the concept of patient education and having a mental health specialist as a key member of the team was Dr. Vijay Gaonkar. This is a picture from our last camp held in Lonavala 2 years ago. Last year, we did not have a camp. Thank you.